هشام ان انا في منتهى السعاده ان احنا معانا النهارده 2 كانديديت من كانوا معانا في الماجستير والدكتوراه. فده كان احد الحاجات الاهداف بتاعتنا ان احنا نطلع جنريشن تشتغل في الحته دي. بسمة هتتكلم على البري والبوست اوبراتيف MR ايميجينج في الماجستير، وبعد كده هننتقل لتامر في المحاضره الجايه ان شاء الله. اتفضلي يا بسمة.
شكرا لحضرتك دكتور رانيا. اولا عايزه اشكر دكتور رانيا، شيز ماي منتور. هي علمتني كل حاجه في الفيلد بتاع البلفيك فلور بصراحه from the scratch، فاي owe her اي حاجه انا عارفاها عن البلفيك فلور. ميرسي يا دكتور رانيا. تكمله الكلام دكتور رانيا، احنا هنجو through the surgical approaches to treat different pelvic floor dysfunctions بس في الفيميلز regarding the anterior and middle compartments only. ده الجزء اللي احنا كنا عاملين عنه رساله الماجستير بتاعتي، how to treat multiple pelvic floor dysfunctions في females and how to go or to aim at حاجة اسمها defect specific approach. هو مش بيتحرك. Okay. As an introduction, pelvic floor dysfunction increasingly بقى common health problem بتأثر على quality of life of many females nowadays. وبتأثر على their life and their daily activities. So a lack of understanding. معلش أنا آسفة، ممكن نور؟
النور.
The lack of proper understanding the underlying cause أو exact underlying mechanism اللي بتحصل بيها ال pelvic floor dysfunctions دي، اللي مش مخليانا نعرف how to properly evaluate the cases and how to plan for the proper surgical management. وده خلى الريت بتاع ال recurrence post-operatively as high as 29% owing to the either surgical failure or complications post-operatively. So الرول بتاع ال MRI pre and post operatively would be divided into pre-operatively أهم حاجة to pinpoint زي ما قلنا the underlying mechanism. Okay. Underlying the exact mechanism اللي حصل بيها pelvic floor dysfunction, thus helping in the initial planning for the surgery optimal for the patient. post operatively عشان نشوف البروسيجرز اللي اتحطت دي او احنا حطينا meshes or slings بال MRI and also to evaluate for complications if any. Regarding the surgical background, stress urinary incontinence in female would be treated by two main mechanisms. It's called the mid-urethral slings. It is put in a tension-free manner. It's divided into retropubic and non-retropubic. The non-retropubic, it's called transobturator tape or a single incision. This is the shape of the polypropylene mesh applied or the slings applied for the case of stress urinary incontinence. When we say tension-free tape, we mean the application of the tape in a tension-free manner. It's a minor procedure that is placed either transvaginally or transabdominally underneath the urethra. So how to visualize the retropubic sling by MRI? Here we have a diagram illustrating أنا بس عايزة أشاور. Sorry. الدياجرام ده illustrate إن عندي هنا دي اسمها retropubic sling. It is put in a U-shaped manner, a narrow U-shaped manner underneath the urethra. بتتحط كده وبترجع retropubically. So how to translate this into MRI? Here at the MRI we have the T2 images. The solid black arrow بيشاور على retropubic sling. The hypo-intense linear structures passing retropubically هي دي السلينجز اللي احنا بنتكلم عنها. ال U stands for the urethra and تحتها ال vagina collapsed. So the hypo-intense structures passing retropubically هنا pointed to by the black solid arrow أو هنا ال white arrow هي retropubic slings اللي احنا بنقولها. Another نفس الدياجرام اللي بيقول على retropubic sling نشوفها ازاي in a coronal reconstruction. We can see the hypo-intense dots on both sides or on either side of the urethra representing the arms of the slings. B stands for the bladder. Here at the sagittal reconstruction, we can see the symphysis pubis, and behind the symphysis pubis, the hypo-intense linear structure representing the arm of the sling passing retropubically. The other option would be the mid-urethral sling. The difference between the retropubic and non-retropubic is the way the arms of the sling passes. Here in the retropubic sling, the transobturator tape, which is non-retropubic, the arms of the sling passes laterally in a rather opened angle rather than the retropubic sling towards the obturator foramina. How to visualize it? Here is the diagram translated into an MRI image. Here at the MRI image, we can see the hypo-intense T2 structures passing underneath the urethra as well, but directed more laterally towards the obturator foramen in an opened manner rather than the narrow angle caused by the retropubic sling. U for urethra, V the vagina, and R is the rectum. Regarding the middle compartment, as Dr. Rania referred to, the compartments at the pelvic floor are anterior, middle, and posterior. Anterior, we refer to stress urinary incontinence and how to manage it. Middle would be the uterine descent or prolapse and how to manage it. So the pelvic organ prolapse is treated either by the famous sacrocolpopexy mesh or the vaginal meshes, either placed anteriorly or posteriorly. So how to visualize the sacrocolpopexy mesh by MRI? Here is the diagram showing the upper part of the sacrocolpopexy mesh being fixed to the sacral promontory by stitches. And here's the anterior and posterior arms of the mesh stabilizing the anterior posterior wall of the vagina here, as here is no rectum in case of hysterectomy, or the walls of the vagina and the rectum in case of rectal and cervical prolapse. To translate this image into an MRI, sagittal MRI, we can see here the hypointense linear band extending from the sacral promontory as a fixation point to the vaginal apex and passing through the anterior and posterior walls of the vagina for the aim of fixation. So this diagram is just like looking from upwards towards the sacrocolpopexy mesh. We can see the both.
ممكن الصوت ورا اللي
انتوا سامعين صوتي كويس؟ Okay.
كان في صوت ورا بس جاي.
اوكي دي الدايجرام ده بيبين التو arms بتاعت sacrocolpopexy mesh being placed to the sacral promontory by sutures as I mentioned before, and the translation of this image into an MRI axial T2 image showing this hypointense structure, which is the two arms opposed of the sacrocolpopexy mesh being placed or fixed to the sacral promontory. This is a coronal reconstruction image showing as well the arm of the sacrocolpopexy mesh. This is the upper end, and this is the lower end, which will be divided into anterior posterior parts fixating the vaginal walls. Other option for pelvic organ prolapse would be the vaginal mesh. The vaginal mesh has two arms, as we see, the anterior arm passing anteriorly through the obturator foramen and the posterior arm passing posteriorly towards the sacrospinous ligament, and here is how it looks like. So how to visualize it? We have here the solid black arrow and the solid anterior and posterior arrows. The anterior arrows refers to the anterior part of the vaginal mesh, and the posterior arrow, which is dotted, refers to the posterior arrow of the vaginal mesh, which are hypointense on T2. All the slings and meshes should be hypointense on T2. Here is another picture showing the anterior arm of the vaginal mesh as well, referred to by the solid black arrow. And here's a diagram translating the arms of the meshes and the corresponding sagittal MRI showing the anterior and the posterior arms of the mesh as well as an hypointense linear structures fixating the anterior and posterior vaginal walls. So, بنستخدم التكنيك بتاع الام ار اي ازاي؟ زي ما دكتور رانيا قبل كده قالت احنا عندنا ام ار اي بروتوكول اند بيشنت بريبريشن. بيشنت بريبريشن حاجات ما بنختلفش عليها بتاعه تحضير العيان للام ار اي. Regarding the enema or pads, برضو زي ما دكتور رانيا قالت pads to avoid the soiling of the table and the patient. Rectum would be opacified by 100 ml ultrasound gel. The doctor should attend the exam to make sure that every single step is made correctly عشان في الآخر ناخد الفحص كله على بعضه صح ونقدر نعمل interpretation صح ونعرف the underlying cause of the pelvic organ prolapse or the stress urinary incontinence in these cases. البروتوكول اكيد مش هقوله بعد دكتور رانيا، قالته بشكل وافي either static or dynamic or MR difficography. So cases to demonstrate what I have said, we have this patient, 48-year-old female patient, came preoperatively complaining of pelvic pain, heaviness, sense of incomplete evacuation, and stress urinary incontinence. And she underwent a uterine mesh placement and she had a successful outcome. احنا بنقول successful و unsuccessful هنا عشان الرسالة بتاعتي كانت بتcompare ال successful patients وال unsuccessful patients وعشان نعرف بالظبط ايه اللي حصل intraoperatively والinterpretation بتاعه في الimaging. So this is the first case. بنشوف ال MR difficography بتاعها، نبلوت ال PCL line زي ما احنا عاملينه في الصورة، ونشوف هنا في الراكتوسيل post operatively if we plotted the same line هنشوف ان ما بقاش في راكتوسيل. ودي post operative static axial T2 images of the mesh for evaluation of the mesh arms نفسها, the right and left arms referred to بالred arrows, وشايفين مفيش أي signs of complications as a scarring or irregularity or collections. So case number 2, it's a 40-year-old female patient with a preoperative complaint of stress urinary incontinence as well. Post-operatively بتشتكي من deep pelvic pain, dysuria, and wound infection, clinically elicited wound infection. So she had a hysterectomy 8 years ago and sacrocolpopexy mesh placement. Regarding the difficography assessment, she had a cystocele, a peritoneocele here, and a rectocele. Post-operatively, feed resistance of the cystocele we saw pre-operatively as well as the peritoneocele and the rectocele. Pre-operatively, we here compared the static axial images of the patient. The static axial images of the patient would evaluate a very important aspect, which is the endopelvic fascia, which is underrated regarding the clinical point of view. Here we have the horizontal posterior aspect of the urinary bladder indicating an intact endopelvic fascia level 2. Post-operatively, we have the saddlebag appearance. The saddlebag appearance indicates that we have a weak endopelvic fascia led to the sagging of the posterior aspect of the urinary bladder instead of the horizontal intact line. Here we have pre- and post-operative coronal images of the patient underwent sacrocolpopexy mesh placement. Here there is no mesh, no hypointense structure. Post-operatively, we can see clearly the hyperintense linear structure against the hyperintense T2 fat. Pre-operatively as well, we will compare the sagittal images. Here we do not see the hypointense line being fixed to the sacral promontory. Post-operatively, we can see the linear structure passing through, fixed to the sacral promontory and passing through the fat to be administered to the anterior and posterior vaginal wall for fixation. In this particular case, we suspected an element of infection on the clinical base. So we added a contrast to the examination of the patient. Here's the pre-contrast images, and here is the post-contrast images. Clearly, we can see a collection surrounding the mesh, the hypointense structure we refer to here, indicating an element of infection, which corresponds with the clinical data. Here's a zoomed in axial T1 showing that there is a collection and also there is a fluid level within the collection. So, and diagnosis of the right mesh arm area of low collection and abnormal contrast enhancement was made and established. The third case would be a 30-year-old female patient came with for stress urinary incontinence and dyspareunia. Post-operative, she reported deep pelvic pain radiating to the back and no clinical complaint regarding her stress urinary incontinence. She underwent a tension-free tape transobturator tape placement. So we retrieved her preoperative data for comparison. The difficography revealed the cystocele, which is the descent of the urinary bladder below the PCL line, which is rather present post-operatively, and here we can see the horizontal orientation of the urethra indicating the urine leakage during evacuation or difficography. Here's the axial images showing here fat, showing no arms of the sling, or we cannot plot the hypointense structure. As well, post-operatively, we can clearly see the hypointense arm of the sling against the fat. The coronal image as well, we can see by comparison, no arm of the sling, hypointense arm of the sling. Sagittal, no arm, hypointense arm post-operatively. So this is just to correlate, between the images here. This is what we see and the corresponding part on the axial image. After IV contrast administration for the same purpose, we can see post-operatively an area of edema as well as a minor collection surrounding the arm of the sling. So as well, we diagnosed a post-TVT, transobturator tape placement edema and inflammation, as well as vaginal fornix edema. Mild cystocele, as I said, was present. The horizontal urethra orientation was reported. So what's the recommendation for proper MRI imaging? We would recommend thin slice thickness that will enable us to see the fine hypointense structure being placed for treatment of different pelvic organ prolapse or stress urinary incontinence. So the thin slice thickness would be okay. The narrow field of view, and in case of infection, we would add contrast. So the take-home message that there are various types of surgical procedures being applied for multiple pelvic organ prolapse and stress urinary incontinence symptoms, and we need, as a radiologist, to be aware of the appearances of such structures being placed by the surgeons in order to properly evaluate them. We should look for hypointense linear structures whenever we know that it is being placed. For a retropubic sling, we should look behind the symphysis pubis, traversing the rectus fascia. For tension-free tape, transobturator tapes, we should look towards the obturator foramina and periurethral. For vaginal meshes, as I said, we should look anterior and posterior to the vaginal walls. For sacrocolpopexy pexy mesh, we should evaluate the sacral promontory for the fixation point, and to detect, again, the vaginal fold for the anterior and posterior arms of the mesh. So, as well, we need to know that differentiating between the scar and the mesh or tape being placed may be difficult sometimes. So we need to properly examine the mesh we need to evaluate. That's it. Thank you.
شكرا يا بسمة على البرزنتيشن. هي معلش هي تقيله عليكم شويه، بس دي بتديكم فكره ان المجال لو حد عايز يبتدي ريسيرش في حاجه جديده عشان تقدروا تنشروا بيبرز، موضوع البري اوبراتيف ام ار ايمجنج للبلفيك فلور ديسفانكشن ده موضوع فيري برايم وممكن تبتدوا تشتغلوا فيه وهيبقى النشر فيه بسهوله جدا. ميرسي يا بسمة.
نكست سبيكر دكتور تامر ابو وهاب. ودكتور تامر الحقيقه قضى جزء مش قصير من